Hello everyone, myself Dr. Aleena Elizabeth Andrews. I'm a radiologist. I thank Dr. Wernickes sir for giving me this opportunity to present a topic in his YouTube channel, The Shades of Radiology. I'll be presenting a topic on the functional brain anatomy, part 1. Let me outline what I'll be discussing in this lecture. I shall be discussing about the important functional areas in the supratentorium. So these are the areas that I'll be discussing about. So let's take them one by one. I shall discuss about the location of each of these areas, how you can localize them on MRI, and its functional importance. So let's begin. First and foremost, let's discuss about the primary motor cortex. So first question, where is it located? It is located in the frontal lobe. So where exactly in the frontal lobe? It is situated in the precentral gyrus. So where is precentral gyrus? It is seen just anterior to the central sulcus. So map out the central sulcus. The gyre anterior to it in the frontal lobe is the precentral gyrus, and that is the area of the primary motor cortex. So what is a function? As the name suggests, it helps in executing the voluntary motor movements. So if you're getting an insult there, for example, you're getting an acute infarct in that area, how will the patient present? The patient will present with motor weakness. So let's see in this picture, this is the trace diffusion weighted imaging, which shows a bright area where in the precentral gyrus with corresponding fall in ADC. So there is there is a diffusion restriction. So this signifies what? Acute infarct, and this patient will present with motor weakness. Now coming to the second important functional area, which is the primary sensory cortex. So where is primary sensory cortex located? It is in the parietal lobe. So how can you localize it? You first have to draw the central sulcus. The gyre just posterior to it will be what? The postcentral gyri. So that is the area of our primary sensory cortex. So as you can see in the anatomical picture, this is the postcentral gyre, and that is the location of primary sensory cortex. So what is its function? Its function is for central processing of tactile and nociceptive stimuli. Okay, that is sensory information. Now let's come to another important area known as the premotor cortex. So first and foremost question, where will you localize it? Where is it located? Definitely it is located in the frontal lobe. But where exactly in the frontal lobe? It lies rostral to the primary motor cortex. So in order to localize premotor cortex, you have to know where primary motor cortex is. We already know that it is in the precentral gyrus. So map out the primary motor cortex, and just anterior to that you have got premotor cortex. Now in MR image, you can see the axial sections provided. First, you have to identify the precentral gyrus or the motor cortex. So, this is our precentral gyrus. You can identify it by the hand motor nerve configuration. Okay. Just anterior to that, what you see is the premotor cortex. So, what is the function of the premotor cortex? We know that the primary motor cortex executes the voluntary motions like voluntary motor activities. Now, what about the premotor cortex? It is involved in something known as the praxis. Okay, praxis. So, what do you mean by praxis? You have to integrate the sensory and motor information in order to perform an action. So, any motor activity is very complex. It requires multiple inputs, and one such area that is helping out our primary motor cortex is the premotor cortex. Okay. Now, just like the premotor cortex, another assistance is also provided by another important area called supplementary motor area. Now, first we have to localize that area. So, where is it located? Again, it is located in the frontal lobe, but we should know the specific site. So, we have to remember that SMA, supplementary motor area, occupies the dorsomedial aspect of superior frontal gyrus. So, to be more specific, you can remember it as lying anterior to the precentral gyrus or the motor cortex. To be specific, anterior to the foot motor area. So, we have to know that in the precentral gyrus, which is the primary motor cortex, there are different parts of the bodies are represented in different area, like mapping out. It is known as the motor homunculus. We have learned it in our previous days, right? So, as per the motor homunculus, where is the foot motor area located? It is located in the far medial aspect. So, if this is the precentral gyrus, where will the foot motor area be located? It will be in the far medial aspect. So, this is somewhere where the foot motor area will be represented. Now, to localize SMA or supplementary motor area, remember that it lies just anterior to the foot motor cortex. So, this is our location. And saying the boundaries, laterally what do you have? Laterally it is bounded by this premotor cortex. Posterior, of course, we have the foot motor area, and medially it is bounded by the interhemispheric fissure. So, this area is a supplementary motor area. Now, when you are trying to figure out on axial sections, where will you look for? You have to look in the medial most aspect. So, first localize the precentral gyrus, and to be specific, localize the foot motor area. So, we know that this is the region of precentral gyrus. The foot area will be located most medially, right? So, somewhere over here, just anterior to that, you have the structure called the supplementary motor area. And remember, supplementary motor area is further divided into two parts. One is the motor supplementary area, or the SMA proper. The other one is the language supplementary area. Okay. So, what is the function? So, we know primary motor cortex is required for executing voluntary action, but you have to plan it. It's a very complex process. For example, I have to take a pen kept in front of me. So, I have to move my hand and pick it up. So, there are subtle calculations made. How much my hand has to move, how to pick up. All this planning is done by whom? Our supplementary motor area. Okay, so SMA is responsible for planning of the motor movements, and the pre-SMA or the linguistic areas for the linguistic planning. Okay, now let us just summarize whatever we have learned so far. First and foremost, we have learned the primary motor cortex. Where is it located? In the precentral gyrus. So first you have to map out what? The central sulcus. Anterior to that you have got the precentral gyrus, which is our primary motor cortex. Now we have to see the primary sensory cortex, which is in the postcentral gyrus just behind. Then we have seen two additional areas, assistants to the motor cortex. One is the premotor cortex, which is located just anterior to our primary motor cortex. So this will be that area. And the SMA or the supplementary motor area, which is located anterior to the precentral gyrus. Where exactly? Just anterior to the foot motor area. So this is our area. Okay. Now, what is the clinical significance of supplementary motor area? Supplementary motor area, if you get any insult in the form of a tumor or infarct, which infarct? ACA tertiary infarct. Why ACA? Because that occupies the territory, frontal lobe supplied by the ACA, medial most aspect of the frontal lobe, so supplied by ACA. So ACA infarcts or a tumor involving SMA will result in classic conditions called ebulia or gait apraxia and transient weakness. So what do you mean by ebulia? There is a lack of initiating capacity, drive or willingness to do things. Okay. So you get ebulia or gait apraxia. All these are features of lesions affecting the supplementary motor area. Now coming to next important area, which is the supramarginal gyrus. So first and foremost, the location. Where is it located? It is located in the parietal lobe. So where exactly in the parietal lobe? It is actually a horseshoe shaped structure. So this is the anatomical image. Horseshoe shaped structure which is seen capping a very particular important structure. What is it? It is a sylvian fissure. So we know that this is a sylvian fissure. At the far lateral end of the sylvian fissure, capping it lies our supramarginal gyrus. So when you're looking at the brain from above, like the axial section, where do you expect? It is seen laterally, okay? Somewhere over here. So looking at the MR images, best to identify would be in a sagittal section, because we have to trace the sylvian fissure, and the most ascending part capping it, you have got the supramarginal gyrus. Now what's its importance? Its function lies in the phonological processing, that is of the spoken and written language, and also in the emotional response. So when you get a classically an infarct affecting these are the areas affected, okay? These are the functions affected. So this is a classic image showing infarct affecting the supramarginal gyrus. As you can see an axial image, it is located far lateral, right? Now coming to yet another important structure is called the angular gyrus. So where again is angular gyrus? It is also a part of parietal lobe. So remember that the angular gyrus and the supramarginal gyrus together form an important structure called the inferior parietal lobule, okay? Together they form the inferior parietal lobule located in the parietal lobe. So if the supramarginal gyrus was capping the end, lateral ascending end of the sylvian fissure, where how can you identify angular gyrus? Angular gyrus also will cap a sulcus. Which sulcus? It is known as the angular sulcus. So what is this angular sulcus? It is the ascending aspect of the superior temporal sulcus. So as you can see, this is the temporal lobe. This is the superior temporal sulcus. The most ascending part, that is known as the angular sulcus, and the parenchyma capping it is the angular gyrus. So on MRI, how can you see? You have to first trace out the superior temporal sulcus. Okay, the ascending most part, this one is the angular sulcus, and the capping it, the parenchyma, is our angular gyrus. Now, what is its function? It is involved in what? Language, number processing, memory, and reasoning. Lots and lots of function. So coming to clinical significance, if you've got a lesion affecting this area, okay, how will the patient present? The patient will present with a syndrome called Gerstmann syndrome. We have studied it previously, Gerstmann syndrome, classically affecting angular gyrus. So what are its components? You get agraphia, acalculia, right-left disorientation, and finger agnosia. So these are the components affecting, these are the features when you get a lesion of the angular gyrus, that is known as a Gerstmann syndrome, because it is involved in language, number processing, memory, reasoning, all these functions, okay? Now summarizing the supramarginal gyrus and angular gyrus, remember together they form something known as the inferior parietal lobule. It is a part of the parietal lobe. And how can you identify each one of them? You have to trace out two important sulcus. First is the lateral fissure or the sylvian fissure, and the parenchyma capping it in a horseshoe shaped manner is our supramarginal gyrus. Next you have to trace out which one? Another sulcus, which is a superior temporal sulcus, and its most uppermost aspect, that is called the angular sulcus. Capping it, what you have got? You have got our angular gyrus. So I hope it is clear. Now coming to another important area, functional area, is the Brocas area. So where is it located? It is located in the frontal lobe. Both sides? No, in the dominant hemisphere. Usually on the left, it is located in the dominant hemisphere. Which dominant hemisphere? The frontal lobe. So can you give a further clarity to where exactly in the frontal lobe? It is located in the inferior frontal gyrus, its posterior most aspect. So as you can see, this is a region of frontal lobe. This is our sylvian fissure. So this area of the inferior frontal lobe or inferior frontal gyre, its most posterior aspect, that is the area occupied by the Brocas area. So to be more specific, within the inferior frontal gyrus, it occupies the operculum. Which all part? The pars opercularis and pars triangularis. We shall discuss about these two in a short while. So just remember, it occupies the operculum part of the inferior frontal gyrus of the dominant hemisphere. Now to map out its boundaries, how can you identify it? First, it is limited inferiorly by our sylvian fissure. Anteriorly by what? The anterior ramus of the sylvian fissure. So sylvian fissure sends out few rami into the frontal lobe. So anteriorly it is bound by the anterior ramus of the sylvian fissure. And posteriorly, what is it bound by? It is bound by the precentral sulcus. So anterior to the precentral gyrus, you have got the precentral sulcus. And superiorly, it is bounded by the inferior frontal sulcus. This is how exactly you can pinpoint this area. Okay. Now on MR imaging, again, best view you can go for in the sagittal section. So first you have to identify the sylvian fissure. So just above that, in the inferior frontal gyrus, by mapping out the boundaries superiorly, inferiorly, anteriorly and posteriorly, you can localize the Brocas area. in the dominant hemisphere. So what is its function? It is in the speech production, motor speech area. So any lesion, classically an acute infarct affecting that area, will produce what? Expressive aphasia. So this is the sagittal section showing altered signal intensity in the inferior frontal gyrus. And what about in the axial section? So it is in the inferior frontal gyrus. So you have to go to the base, towards the base of the brain, particularly the opercular part. So this is the area represented by the operculum, frontal operculum. We shall discuss that in a bit. And this is the area occupied by the Brocas area. Okay. When you speak of Brocas areas, inevitable is to discuss about the Wernickes area. So Wernickes area is known as the sensory speech area, right? So where is it located? Brocas was located in the frontal lobe. So where is Wernickes? It is in the temporal lobe. So where exactly? In the superior temporal gyrus, its most posterior aspect. Okay, again in the dominant hemisphere. Usually the left is the dominant. That's why it is said at left hemisphere. It is usually in the dominant hemisphere. So how will you localize? First you have to identify the temporal lobe, superior temporal gyrus, and where exactly? In the posterior most aspect you have got the Wernickes area. So you can see here, right? So this is the connection between the Brocas area and the sensory speech area. Now coming to yet another important area, it is known as the fusiform gyrus. So where is it located? It is located on the basal surface of the brain, occupying which all lobes? The temporal and the occipital lobe. So can you be more specific? Yes. It is outlined by two sulci, which all? Medially you have got the collateral sulcus and laterally you have got the occipitotemporal sulcus. Between these two sulcus, in the base of the brain, occupying both temporal and occipital lobe, you have got fusiform gyrus. So it is also known as the fusiform phase area. Why? Because of its classic function. It is for understanding the meaning of what you are seeing. You are seeing a person. Because your eyesight is good, the optical tract is good, you are able to, and the occipital cortex is good, you can see it. But to identify it as so and so person, or give a meaning to the whatever you are seeing, you need fusiform phase area or the fusiform gyrus. Okay, so how will you see it on brain? Axial sections, you have to go to towards the base of the brain, occipital and temporal lobe. Medially you have collateral sulcus, laterally you have occipitotemporal sulcus. In between, again on coronal section also, it is occupying the most posterior aspect. You can see this area. So any lesion, what will you get? You will get visual agnosia for object. You can see but you cannot derive the meaning. Prosopagnosia, facial blindness. You are not able to recognize faces. Okay, and even pure alexia. Now coming to yet another important area, which is the gyrus rectus. So where is it located? It is located in the frontal lobe, where in the base of the brain, most medial aspect. Okay, it is also known as the straight gyrus or the gyrus rectus. So what is its function? It's not so clear. However, it is involved in higher cognitive function like personality. So any lesion, though, you can get change in the cognition, personality disorders. So again on the axial MR sections, you have to go to the base of the brain, most medial aspect, you get this gyrus. Now this is another important area which we have actually, I've given an insight into it when we were discussing about Brocas area, which is about the operculum. So what exactly is operculum? Operculum is a part of the cerebral hemisphere which is covering an important structure from the external view. So what is it covering? It is covering the insular cortex. So in this section, what you can see, I have retracted the brain parenchyma like this so that I am able to see one important structure known as the insular cortex. So when I move the retractors, what will happen? These lobes, the cerebral hemisphere, will come together and cover this insular cortex from the external view. So the part of the cerebral hemisphere covering the insular cortex from the external surface is called as operculum. So what all operculum you have? You have got the frontal, parietal and temporal lobe. So this is the area of frontal, you get area of parietal here and temporal operculum over here. Okay, together they are covering the insular cortex, hiding it into the depths. So in the cut section of the brain, this brown area here, that is our insular cortex, and covering it externally you have the frontal operculum and the temporal operculum. Okay, frontal and parietal operculum are together called as frontoparietal operculum. Now remember that the frontal operculum is further divided into three important parts, and they are known as the pars orbitalis, pars triangularis and pars opercularis. Okay, by the ascending rami of the lateral fissure or the sylvian fissure. You have got the anterior ascending rami, you have got the ascending rami, and this divides the frontal operculum into three parts. And as we have learned, the Brocas area occupies the opercular and triangularis part of the operculum, frontal operculum. Okay, so this is the operculum. Remember, there are three operculums. You have got the frontal, parietal and the temporal lobe. Okay, so as you can see, this is our insular cortex, and this is the frontoparietal operculum, and this is our temporal operculum. Now finally, coming to another important structure, last topic on today's lecture, which is about the optic radiation. So what is optic radiation? It is a part of the visual tract, also known as geniculocalcarine tract. So where does optic radiation go? It starts from the thalamus, fans out and ends in the primary visual cortex in the occipital lobe. So where exactly in the thalamus? From the lateral geniculate body. So far lateral of the thalamus, posterior part, you get the lateral geniculate body. From there you get the optic radiations fanning out like this and terminating in the primary visual cortex. I hope so far it's clear. What are the important? These are only few of the important functional areas of supratentorium. So you should know how to localize them anatomically. That is also on MR images, and should know its functional significance. So next time when you're reporting a case, try to identify it based on the functional aspect and correlate with clinical symptoms rather than just mentioning it as frontal lobe, temporal lobe or parietal lobe like that. So I hope that's very clear. Thank you very much.